Class, this is Kelly Neal again, and today we're going to talk about paced rhythms. So our first part of looking at paced rhythms is why would we need them? Okay, why would we need to be using them? And so what we're going to see here with our paced rhythms is generally indications for a pacemaker is going to be symptomatic bradycardia. So when you have those slow rhythms, the sinus bradies, the junctional rhythms, idioventricular rhythms, things that are really slow, they will frequently need help. You can only give so much atropine for a bradycardia before it's time to determine that you really just need to go to a more definitive treatment. Another thing is sick sinus syndrome, where the sinus node is just starting to poop out, and the pacing sites are starting to wander between the pacemaker, the junctional area, the ventricles, and it's really not enough to support the person anymore because it's going at a slower rate. We might see it for second-degree heart blocks, especially type 2s more than type 1. Type 1 heart blocks a lot of times are transient. The person will come in and out of them, but type 2 heart blocks usually need more definitive treatment. And third-degree heart blocks, which are known as our complete heart blocks, will frequently need a pacemaker. The other time we might see this is with chronic atrial fibrillation with a slow ventricular response. Sometimes with our atrial fibs, when we're giving them medications and their ventricular rates are really slow, they might end up needing a pacemaker to kind of help augment things. So the next thing we'll look at here is what type of pacemaker do we need? There's what we call an external pacemaker. And an external pacemaker is when you take your defibrillator machine, and most defibrillators have the ability to defibrillate, to cardiovert, or to pace. So you put your electrodes on, and usually we do the electrodes more of a front-back approach, where we put one right over the front of the heart and then roll them over and put one on the back. And you press the button that says pace, and then it will come up at a rate. Usually we pace at a rate of 60 to 70, and then there's a button that'll say milliamps, and you'll turn the milliamps up, and you'll keep turning them up until you see capture happen. So external pacing is a temporary measure. It is something that is usually only used for a couple hours because it takes a lot of milliamps with an external pacemaker. External pacemakers have to go through muscle, bone, fat before it can make the heart pace, and that's really uncomfortable for a person, so they don't tolerate these very well. They frequently are going to actually need sedation and some pain medication to be able to tolerate it. So our next one we'll look at is a temporary pacemaker. Now, a temporary pacemaker is also a lot of times known as a transvenous pacemaker. And with these, the physician would put a wire directly into the heart. So the wire is usually threaded through the superior vena cava, and the wire will get embedded into the heart muscle. And then what happens is you turn the button on. You turn it on right here. You set your rate, and so usually we will set it at a rate of around 70. And then the milliamps, or the output, you start turning that up until you see the pacemaker fire and until you see capture happen. Now, because this current is going directly through a wire and going directly into the heart, generally this is only going to take 8 to 10 milliamps of current to get capture to happen, where with our external pacemaker, it'll frequently take somewhere from 40 to 80 milliamps of current before you have a capture happen. Then, of course, there's our permanent pacemaker. Now, the permanent pacemaker has a pulse generator here. So the pulse generator has a battery in it, and it's usually a lithium battery that will last for years and years and years. And then there's pacing wires or pacing leads. And these pacing leads, there will be one or two, depending on whether they are being paced in the atria or the ventricles or both. And these pacing wires they're attached to the pulse generator, and then they come in through the superior vena cava. And if you have one into the atria, it'll get attached to the atrial wall. And if you have one going into the ventricle, it's going to attach to the ventricular wall. And usually they have these little tines on them, which will help kind of embed into the muscle of the heart. Remember, with the heart, the inner layer of the heart, the endocardium, it is made of smooth connective tissue, but there's a lot of little valleys and folds in there. And so they kind of embed those tines into those valleys and folds, so it'll stay, so it'll actually make that attachment. So with our pacing generator here, and we've got our pacing lead that comes off, and this will get embedded into the heart muscle. They'll either have tines here at the bottom of it, or they'll have kind of a screw-in lead where they just kind of screw it into that muscle of the myocardium, just so it'll stay put and give you your impulse reading. Now, pacemakers nowadays are very thin. They're very thin. They're very small. The original pacemakers that were made 50 years ago were more like the size of a deck of cards and probably a half-inch thick that were used to pace the heart. So now they're extremely lightweight, very small. Pacemakers, the pulse generator is generally going to get embedded into the subcutaneous area of the chest, up here in the upper area of the chest. Most of the time, the physicians come in from the left side and they'll embed this into a pocket, into a subcutaneous pocket here in the chest. They thread the lead in through the superior vena cava, or through the subclavian vein, and it's going to come in through the superior vena cava. They can do it from the right side as well, but generally they find it, most of the time they'll come in from the left. Just the natural flow of the wire tends to go in a little bit better. So this will usually look just like a hard lump right underneath the skin. Again, here's what our pacemakers look like, and they're just getting thinner and smaller every year, it seems like. And how long a pacemaker generator will last is going to depend on how long they are paced for. So if the person is in a paced rhythm 100% of the time, 24/7, generally 8 to 10 years might be the max that pacemaker might last for before it's going to need a new battery in it. Where if they're in their own rhythm half the time, they're only paced half the time, that battery may last a lot longer. So the pacemaker will look kind of like a hard lump underneath the skin. On a chest x-ray, it will glow. It will show up on a chest x-ray. Now, it's always a nice thing for patients to know what their pacemaker is supposed to do. And normally when a person has a pacemaker inserted, they're given a card that will tell them what the pacemaker does so they can pass that information on if they ever get admitted to a hospital. But let's face it, in reality, many of our patients come in and we see that they have a pacemaker because we see the hard lump under the skin, or we put them on the monitor and we see they're in a paced rhythm, and we ask them what type of pacemaker they have, and they have no clue. So pacemakers have a code to them, okay, a pacemaker code. And it'll kind of give you an idea of what we should expect that pacemaker to do. So your first letter of your pacemaker code, if it is an A, it means it is going to pace the atria, just the atria, not the ventricles. If your first letter is a V, we know it's going to pace the ventricles, not the atria. But if your first letter is a D, that means it is a dual pacemaker. It will pace both the atria and the ventricles for you. Now, your second letter is the chamber that is sensed, and that means it can read the person's underlying rhythm. It can look for the person's own atrial beats or their own ventricular beats. And so if the second letter is an A, it means that it will sense the person's atria only. If the second letter is a V, we know it will pace the ventricles only, or sense the ventricles only. And if it's a D, we know it has the ability to sense the person's underlying atria and the underlying ventricles. If there's a 0 there, then it means it can't sense anything. And you just don't see those anymore. The first pacemakers that were made many, many years ago, just paced. They didn't have the ability to sense the person's underlying rhythm. But nowadays, all of the newer pacemakers do. The third letter is going to be the mode or response to sensing. So what that means is if you have an I there, it means it's going to inhibit itself. So if it sees that, so let's say I have an atrial pacemaker and it senses the person's own atria, it will inhibit itself from firing. If that person's atria, if their own beat is firing, it's going to inhibit the pacemaker from firing. If it has a T, it means it will be triggered by what it senses. So instead of inhibiting itself when the atria go to fire, what it's looking for is when the atria doesn't fire, it's going to give the person's own rhythm a chance to fire. And if it doesn't fire by that time, it will trigger the pacemaker to go. So it can be inhibited or it could be triggered by different settings of the machine. If it's a dual If you have a D there for the third letter, it means it can both inhibit, and it can inhibit itself when it sees the person's own underlying rhythm, and then trigger when the person's underlying rhythm doesn't kick in by a certain point. And if there's a 0 there, it means no response. Now, the fourth letter is rate responsiveness. The pacemakers nowadays, what they found with the original pacemakers were that original pacemakers, they couldn't speed up. You would have a pacemaker and you would set it at, say, a rate of 70. And so these people, their heart rate would be a rate of 70, and that would be it. But what if you had a really active person, and this person, they still go rock climbing, they still run, they still hike? Normally your heart rate speeds up to bring more blood and oxygen to your muscles and your cells. But if you have a pacemaker set at a rate of 70 and that's all you get, people were feeling really tired, really fatigued. So they started making rate responsive pacemakers, and pacemakers that could be programmable to do other things. And they even have pacemakers now that can defibrillate if the person tends to have a tendency to go in lethal arrhythmias. But the rate responsive ones, what they do is they will have a low rate, so the minimum that person's heart rate is going to be a 60 or 70, whatever the rate is set at, but it'll also be set for an upper limit of, say, 110 or 120. So if they're active, if they're, and there's movement sensors in these pacemakers, and so they start seeing that those arms are moving like they're jogging or they're vacuuming or they're climbing, it's going to start speeding the rate up of the pacemaker to try to bring them more blood flow so they won't get as fatigued. So the most common pacemakers that we are going to see is a DDD pacemaker and a VVI pacemaker. A DDD pacemaker, it means it's going to pace, it'll have 2 wires to it. It's going to pace the atria and the ventricles. It's going to sense the person's own atria and the person's own ventricular rhythm, what it's doing normally, and it will inhibit itself or trigger itself depending on what it sees. Now, this is most clearly mimics normal cardiac function. This is what the heart normally does, and so this is the most common type of pacemaker to be used. Now, a VVI pacemaker is another type of pacemaker we tend to see, and with a VVI pacemaker, it will pace the ventricles. So it has 1 wire in it, straight into the ventricles, none into the atria. It will pace the ventricles. It will sense what the person's ventricular rate is doing, their own beats, and it will inhibit itself if it sees the person's own rhythm, so it doesn't deliver an impulse to the ventricles when their own normal ventricular beat is kicking in. So the thing is DDD pacemakers most commonly are used because that mimics normal cardiac function. But sometimes you still might see a VVI pacemaker. And the advantage to having a VVI pacemaker is if you had a patient, for instance, that had atrial fibrillation. So let's say they've been in atrial fibrillation for 5 or 10 years. They've been in it for years. We've tried to get them out of it. They keep going back in it. So then we just give them medication to control their rate and usually some blood thinners, and they live in it. This is what they're going to live with. And now they need a pacemaker. If we give them a DDD pacemaker, that first time that atria goes to contract, if there's any blood clots in there, it's going to just shower the person with blood clots. So if that person has not been having their atria contract for years because they were been in AFib for years, they'll usually just put a ventricular pacemaker in and pace them ventricularly for the ventricular rate. So I think we're going to stop here and we will continue in the next session.